Good evening, everyone. Today, the topic of discussion is approach to joint pains. So, we'll go about many patients will come with joint pains. Because some will come with small joint pains. Few people will come with large joint pains. So, before going into diagnosis of what is the diagnosis, how do you treat those patients, we need to understand whether it is a proper joint pain or periarticular tissue that is causing the like any ligament or tendon that is causing the joint pain. So we need to classify it and we need to differentiate it clearly before telling what is the next step of management and next treatment plan for the appropriate cause. So first, what kind of pattern is there? How do you diagnose the patient? How much disease activity is there is very important in diagnosing. So first we need to differentiate articular and non-articular. So how do you tell it is an articular and non-articular, whether it is inflammatory or non-inflammatory, how much duration it has been lasting. So then you will tell about what kind of pain it is. So articular pain is any problem in the joint that is generally a diffuse deep pain, and it is generally cannot be localized. It is more diffuse in the joint space. Whereas non-articular pain, like when there is a tendon attachment, where there is a bursitis or tendinitis something, it is generally away from the joint lane. It is not generally located in the joint space per se. It is generally located away from the joint lane, and how you can properly tell here it is there is my pain. So that is probably due to some tendinitis or some bursitis, like in the case of tennis elbow or golfer's elbow, where the lateral and medial epicondylitis, they can properly locate where the pain is located, exactly where the tendon is being inserted. So in the case of articular pain, there is a both movement restriction, both active and passive. So what is active and passive? So active is when you ask the patient to do the movements, like ask him to flex the knee or something, he'll have pain. So if you flex the knee, it is called passive movement. So generally what happens in the case of articular, both active and passive movement, there will be pain because the joint is itself is involved. Where in the case of non-articular pain, generally the pain will be more in the case of active movement because it involves a lot of ligaments and tendons. When you are trying to passively flex or passively extend, the pain won't be much because you are not actually straining the ligaments or tendons much. They are not actively involved. So the limit and the more limited range of motion or pain is more in both active and passive in the case of articular when there is joint pain per se. And also when you are having only pain when you are doing the active movement, there is no pain or pain in the case of passive movement. That is mostly non-articular pain second to some tendon or some ligament insertion, some bursa around it. So that is a non-articular when mostly a tendon or ligament injury. So generally when there is a joint involvement, you find some symptoms like redness, there is swelling of the joint, redness is present, deformity is present, and crepitus is present. Joint instability also, it is hypermobile or hyperextensile. You can do anterior arthritis, posterior arthritis. They are all mostly ortho-related problems, but you need to localize whether it is a joint-related problem or just a periarticular problem. Joint-related problem will mostly have swelling, redness, if it is inflammatory, swelling, redness, deformity, some crepitus in the case of osteoarthritis will be there, and pain will be both in active and passive movements, like active movement but both passive. In the case of non-articular pain, only the pain will be in the active movements, when you are doing passively, not pain will be significantly decreased. And in the case of non-articular, where there is a tendinitis, you will properly localize it. Example, in the case of medial epicondylitis and lateral epicondyles, you can exactly localize where the pain is and where you can actually locate. In the case of articular, it is more diffusely around the joint. So this is the articular, all joint movements. Generally articular, all joint movements are painful. In the case of periarticular, only selected movement, whichever the tendon is involved, that is more involved. And active and passive are generally pain in motion. Active is more common, causes pain. When passive, generally pain is decreased significantly. And range of movement is generally globally reduced. Active, limited. Passive is generally fully you can do it completely because joint space is not involved per se. Passively you can do because you are relaxing whatever, you are not involved in the tendon. Activity is limited. So generally pain is there in specific maneuver, in the case of a golfer, when he is playing in his golfing, it is there in the pain. When he is doing the other movements, there is no proper pain or something. So the pain is triggered by specific movement in the body. In the case of periarticular, when that particular tendon is involved. So joint line, you will find tenderness, swelling. Generally tenderness is away from the joint line. So there are other pains also. Example, in the case of in the case of neuropathic pain, that can be referred pain also. First I'll go into referred pain. In the case of cholecystitis or an acute MI, you will find shoulder pain, radiating, that is nothing related to shoulder or something. So in the case of joint pains also, you need to understand some of them are referred pains in the case of some secondary systemic complaints. Example, in the case of polylithiasis or acute MI, they'll have radiation to the radiation to the shoulder. In the case of meralgia parasitic also, because of nerve compression, you'll have the pain in the lateral wall of the thigh, but that is not per se related to the shoulder per se. But there might be some neurological problem, like in the case of meralgia parasitica, or something that is more of there is a parasitic quality also there, and is more of radiating quality pain along the nerve supply. In the case of referred pain, you can classically it's because some systemic problem, acute MI. There is also other associated symptoms. In the case of MI, diaphoresis, sweating, or their cholelithiasis also will have other jaundice or something, other pain, referred pain, and it is nothing related to the shoulder movement, is not affected, anything. You don't have any aggravation, any restriction of movements, or any joint swelling, nothing is there. So it is mostly a referred pain. So when you are looking at the joint pain, you need to understand whether there is an articular pain or periarticular pain, or it is some related to neural. Example, in the case of cervical spondylitis, they will classically tell, because of the nerve compression, they have radiation of pain from the neck to the shoulders. That is not a shoulder related problem in them. So you should always examine the joint per se, whether there is a movement restriction, active and passive movements is there, whether the joint swelling or crepitus is there. So that involves the joint involvement is there. If it is not there, there is some other cause. So then you look for periarticular, if there is tenderness, if there is aggravated by specific movement or not, so specific tendon tenderness is there or not. So if there is certain movement restriction is there, then you look at periarticular. It is still not there, then you look for any the referred pain. So some other cause, some like in the case of any cholelithiasis is there, any MI is there, where the joint itself, joint or shoulder itself is not involved, periarticular area is also not involved, or the some radiating kind of neurological pain in the case of neck, any cervical spondylitis or something. You need to look at all of these causes before labeling it as a proper joint arthritis or articular pain. So this is how you differentiate inflammatory and non-inflammatory pains. In the case of inflammatory pain, they classically present as early morning stiffness. When you ask patient, they'll tell, morning when I get up, I have stiffness in the joint. I need to clench my feet, and I need to do some exercises for at least 1 or 2 hours to relieve the fitness. So then I can start to day-to-day activities. With the activity, they are improving. So the stiffness lasts generally more than 60 minutes. Sometimes minimum of 30 minutes to 45 minutes is minimum. So sometimes anything less than 30 minutes is not classical of inflammatory pain. Generally 30 to 45 minutes is minimum. They have classical stiffness in the morning, and the pain is more in the night, like late second part of the night, because of the inactivity. With the activity, generally inflammation resolves. So because of the inactivity, the stiffness inflammatory arthritis increase in the late nights, like at the early morning 2 or 3. That's in the case of axial spondylitis. In the case of ankylosing spondylitis also, they complain more of the back pain in the early mornings or something, where in the second part of the night, because they have more generally it improves with exercises, it increases with rest. So they will also have signs of inflammation, like you will have joint tenderness, inflammation, swelling is there, and also they will have other systemic symptoms like fatigue, fever, generalized weakness. They will also, in the case of rheumatoid arthritis, you will feel fatigue, generalized weakness, fever is there, and also they have raised inflammatory markers also. So this is important in the case of inflammatory arthritis, where they have early morning stiffness, which are relieved with activity, which are aggravated by rest. That is why pain is more in the second part of the night. They have signs of inflammation of the joint space, where there is tenderness, there is joint swelling is there. They have associated systemic symptoms like fever is there, and also is there, and raised ASR and CRP are there. In the case of non-inflammatory, their pain is increased. In the case of osteoarthritis space, with the evening they increase in the pain. But they also have stiffness, like in the case of inflammatory, but it is more of intermittent stiffness. In the because of the pain, they can't move the joint. So intermittent stiffness, generally lasting less than 30 minutes, is called gel phenomenon. That is present all throughout the day. Intermittently, it will come and go. So that is called gel phenomenon. There are no signs of any tenderness, swelling, or redness. Nothing is there on the joint space. And normally ASR and CRP. Though osteoarthritis is considered as degenerative, there is some amount of inflammation involved in the osteoarthritis also. Sometimes swelling can occur. So osteoarthritis is per se not completely a degenerative arthritis. Sometimes some amount of inflammation is also involved in the osteoarthritis. So involvement, whether it is acute or chronic. Acute is anything less than 6 weeks, chronic or more than 6 weeks. Why is this is important is, so sometimes let me give a case. A 20-year-old female presented with a complaint of bilateral small joint pains associated with fever. So it's presenting last 10 days. So in this case, if you think that this might be a case of a simple viral related polyarthralgia also, polyarthritis also. But this also might be a first time presentation of rheumatoid arthritis. So this is important. So generally rheumatoid arthritis and SLE, all CTDs, and also this crystal related arthropathy, they are more of chronic nature. They last more than 6 weeks. This viral related arthritis, infectious arthritis, generally last less than 6 weeks. That is why at the first time diagnosis, when you are suspecting acute onset, you should rule out the infections and viral causes before going into the labeling it as some rheumatoid arthritis or some CTD related arthritis, some crystal related arthritis, before labeling a chronic disease. That's when acute setup, you always rule out the infection and some viral related polyarthritis, like especially parvovirus B90s, chikungunya, mumps can cause, measles can cause. So these are all commonly can cause arthritis and arthralgia. So they need to be ruled out. So then monoarticular or poroarticular or oligoarticular or polyarticular. Monoarticular is single joint. Generally, single joint involvement is generally not seen in the case of systemic CTDs like rheumatoid arthritis or in the case of SLE or scleroderma, where they classically involve multiple joints of psoriasis arthritis are in them. Monoarthritis generally signifies any trauma. First, you should look at the trauma. If there is trauma to that leg or something, any injury to the tendon, any injury to the ligament, or if there is any septic or infection related, there is some septic arthritis is there, or then you can look for crystal arthritis like gout arthritis, where it can involve grade 2 only. So you need to look at the CPPD, calcium pyrophosphate disease, where the deposit that can involve the monoarticular. And oligoarticular, this is the monoarthritis thing. Whereas oligoarticular, where the 1 to 3 joints are involved. So 1 to 3 joints can be involved in the case of any like septic arthritis. Single joint is sometimes where the gonococcal arthritis, where there is a migratory arthritis that can involve the oligoarticular. In the case of psoriatic arthritis also, where there are 1 to 3 joints can be involved. In the gout arthritis also 1 to 3 joints can be involved. So polyarticular, you should always think for some systemic disease like rheumatoid arthritis or SLE or some viral polyarthritis. Viral also can cause polyarthralgia. Some crystal arthritis, that is psoriatic arthritis, can give polyarthritis. So and also some systemic disease that is manifesting as polyarticular, you should always think of. So additive or migratory. Generally, I'll give you migratory is in the case of acute rheumatic fever. Where acute rheumatic fever generally starts involving knee joint, it goes to ankle, it comes to elbow, it comes to shoulder. All the joints will be finished in less than 1 week to 1 month. So there is a migratory kind. Acute rheumatic fever is more of migratory. And also Neisseria gonorrhea infection is also migratory arthritis. Whereas additive arthritis, in the case of reactive arthritis, what will happen is first it starts involving ankle, then it comes to knees, it will add on. After ankle, knee also, when the knee is there, ankle is also there. That is additive arthritis. This is classically reactive arthritis. So there is a intermittent or fitting complete continuously there. So intermittent is in the case of gout or there is one episode will occur now. Next episode we don't know when it will come also. It might occur 6 months later or 1 year later or 2 years later. Intermittently patient is completely normal. Sometimes rheumatoid arthritis persists, always it persists. But there is a variant of rheumatoid arthritis called palindromic rheumatism, where the patient will have rheumatoid arthritis per se, but they will have only intermittent phase. Intermittent in between the patient is absolutely normal. So this is called palindromic rheumatism. It is a close mimicker of some gout arthritis or viral polyarthritis. Every time that comes, we think some viral polyarthritis, but it is a case of palindromic rheumatism presenting like in the case of rheumatoid arthritis. So that is also a possibility. And that is also intermittent flares are there. That is more of crystal related, gout related arthritis. Sometimes in the case of rheumatoid arthritis, sometimes palindromic rheumatism is a problem where intermittent flares are there. Unlike in the case of general rheumatoid arthritis present as a chronic course where it is present persistently. In the case some variant is there palindromic where it can present intermittently. So this intermittent thing is also important, where the chronic is there, intermittent is there. Peripheral versus central, axial versus peripheral is there. Axial is spine involvement, hip and pelvis, hip and shoulder comes under axial, sternoclavicular joint or temporomandibular joint. These are all axial involvements. So peripheral is small joints, elbow and knees, ankle. These are all peripheral. So all spine, sternoclavicular, temporomandibular joint, hip and shoulder also comes as a central joints only. Small joints are large joint. So small joints are more of inflammatory in nature. Like hand joint, any small hand joint involvement, you think of inflammatory in nature mostly. If it is a inflammatory, small joints generally involve more of inflammatory. There is osteoarthritis in hands also, but small joint involvement, you should always look for the rheumatoid arthritis or some systemic SLE or something, especially in the case of young females. Large joints are mostly degenerative, like a knee knee is generally degenerative. Sometimes ankle joint is generally rarely involved in the osteoarthritis. It is involved in the reactive arthritis per se. So small, which joint is involved is also very important. Generally small joints are more involved in the case of rheumatoid arthritis and inflammatory arthritis like psoriatic arthritis, SLE arthritis. Large joints are rarely involved in CTDs. So generally large joints are more involved in the degenerative arthritis, symmetric or asymmetric. I'll give you a classical example of symmetrical arthritis. Symmetrical arthritis is classically seen in the case of rheumatoid arthritis or some SLE, whereas asymmetrical arthritis are generally in the peripheral spas like reactive arthritis, some psoriatic arthritis, where there is a asymmetrical joint involvement. So these are all very important in classifying what kind of joint is involved. With this introduction, we will go into case-based scenarios. How do you see? What is the X-ray findings? So we kept X-rays also. You'll understand how to see each case. So a 40-year-old female presented with complaints of bilateral small hand joint pains with early morning stiffness lasting for more than 60 minutes and relieved with activity, and also had complaints of shortness of breath, pain on the left side of chest increased on inspiration. So this is a 40-year-old female present with complaint of bilateral small hand joint pains with early morning stiffness. So this is classically looking like inflammatory arthritis of small hand, bilateral, both sides symmetrical involvement is there for more than 60 minutes, relieved with that. A classical inflammatory arthritis, bilateral symmetrical arthritis is there. So, and also complaining of shortness of breath. First thing I want to look at is after you get a patient like this, first you do is what do you do when a patient comes with complaint? You check for any joint tenderness is there, any swelling is there. So what kind of history? Clearly ask for whether it's inflammatory or non-inflammatory arthritis is there, any large joint involvement is there. So any other systemic, any fever is there, fatigue is there, any malaise is there, any malar rash is there, all CTD features. You'll ask for other any uveitis complaint, any eye related problem, because most of the arthritis like spondyloarthritis associated with uveitis. In the case of rheumatoid arthritis also there is association with episcleritis and scleritis. You ask for them any shortness of breath, because rheumatoid arthritis and some ankylosing spondylitis associated with CTDs, ILDs. So you need to ask all these complaints before labeling what kind of. So generally these CTDs are especially involved with the other systemic manifestations. So this is very important to diagnose. So this is a 40-year-old female. She has classically history of inflammatory arthritis from the examination we have seen. Then we asked, there is also complaint of shortness of breath and pain in the left side of the chest. Before going to the systemic complaints, we look at the joint examination, whether tenderness is there. You press on the joint, you check for any tenderness is there, any swelling is there, any redness is there. If it is there, it is classically a case of inflammatory arthritis. So we are now sure it is inflammatory arthritis. What is the cause of inflammatory arthritis is the next important thing. You ask for all the history of CTD, any fever, malar rash is there, any serositis is there, any proteinuria, any kidney function problem is there, any cytopenias are there. You'll ask for SLE. Then you ask for rheumatoid arthritis related symptoms also. Rheumatoid arthritis symptoms like you ask for any ILD is a very chronic in case. So any rheumatoid nodules are the subcutaneous nodules, where you find the case of rheumatoid nodules are there or not. So you ask for all of that history. So then you decide based on what investigation to write. Generally what we write in the case of inflammatory arthritis, one is ANA, one is RF factor. If you need, you can get anti-CCP also if the RF is negative, if you want more significant. Then ESR and CRP. These 4 or 5 things are very important in the case of especially peripheral bilateral small joint. If it is axial involvement, HLA B27 you can also write. But ANA and RF are one thing you write, ESR, CRP. If possible, if you are required, if you have higher suspicion, if RF is negative, you can write anti-CCP also. Then you get a bilateral hand X-ray with HRUS wrist. So then you find what are the findings you see in this case. As you can see in this case, there is periarticular osteopenia is there. There is osteopenia. This blackish thing is osteopenia around the joint. There is periarticular osteopenia in this case. There is also erosive arthritis. You can see erosions here. So this is erosive arthritis. So this erosive arthritis can be seen here. Periarticular osteopenia is there. There is joint space narrowing also. There is narrowing of joint space. There is a difference between the inflammatory arthritis and non-inflammatory arthritis in the case of joint space narrowing. In the case of inflammatory arthritis, generally joint space narrowing is more symmetrical. It is equal on the medial and lateral side. Where in the case of non-inflammatory arthritis, it is more of asymmetrical. So wherever joint bearing is weight bearing is more, the joint space loss is more. So this is a symmetrical joint space narrowing. There is erosions here. There is blackish thing. These both are periarticular osteopenia is there. When you look at here, in the case of rheumatoid arthritis, DIPs are generally classically not involved. Rheumatoid arthritis is one of the exception in the case of rheumatoid. DIPs are not involved in the case of rheumatoid arthritis. So you get there is also periarticular osteopenia, erosions in the carpal bones are also seen in this case. So then this might be a case of rheumatoid arthritis. You set anti-RF factor, anti-CCP, ESR and CRP. So based on this criteria, you labeled as this is Euler criteria for the diagnosis of rheumatoid arthritis based on the scoring system, whether joint involvement is there or not. So more small joints are involved. I don't want to go through all this and tell everything. So this is the small joints are involved, more significant risk of going into rheumatoid arthritis. So rheumatoid arthritis are generally having predilection to the more of small joints like interphalangeal joint, metacarpophalangeal joint. They are more classical involved. Serology, the titer is also involvement. If low IgM RF is IgM against anti-IgG. IgM against IgG, actually the antibodies against. So if it is low titer, less than 3 times the upper limit, scoring is 2. If more than 3 times the upper limit, high positive RF or anti-CCD, score is 3. So ESR and CRP are also included in the score. So less than 6 weeks and chronic more than 6 weeks. This is to one of the so before labeling any acute arthritis or rheumatoid arthritis, you should always look out for any infectious or viral related causes before labeling it as rheumatoid arthritis. So this is the scoring system that is used. Anything more than or equal to 6 is labeled as rheumatoid arthritis. This is the defining criteria for ALR criteria for the diagnosis of rheumatoid arthritis. That involves joints, that is serology, acute ESR and CRP, and duration of symptoms. So these are the other manifestations you look for in the case of rheumatoid arthritis. One is episcleritis and scleritis. Generally, episcleritis correlates with the joint flares. So if there are joint pains, there is active disease is present. So generally, in the case of all CTDs and inflammatory diseases, when there is a flare, you will have some significant parameter that is coordinating. Example, in the case of SLE, proteinuria and dsDNA and complement levels correlate with the disease activity. In the case of rheumatoid arthritis, episcleritis is one thing that correlates with the disease activity, and scleritis can also be present that does not correlate with the disease activity. So episcleritis, you will have reddish discoloration, like you can see reddish color discoloration with veins and arteries, capillaries becoming prominent around the eye. Scleritis is more of it causes vision threatening. It causes scleroma, thinning and bluish discoloration behind on the back. Episcleritis is more redness of eye. So I'll show you the pictures later on episcleritis and scleritis, but episcleritis correlates with the activity. But the most common manifestation is always keratoconjunctivitis sicca. Sicca is the most common manifestation. You can have scleroderma. Periodontitis is one of the risk factors for rheumatoid arthritis also. Pulmonary. I'll tell you, this patient has shortness of breath and pain on the right when he's breathing. So the patient might have pleural effusion also. So one of the classical feature of the rheumatoid arthritis is it has exudative pleural effusion. Generally, that is called most of the pleural effusion in CTD are reactive pleural effusion. So generally, these have low glucose level and all. So the rheumatoid arthritis, and the classical feature of rheumatoid arthritis effusion is also mostly unilateral rather than bilateral. So rheumatoid arthritis can unilateral exudative pleural effusion. That is one of the classical features of. So that's why the patient is having pain on the right side when he's inspiring. So one of the classical, one of the differentiating rheumatoid arthritis, one of the important things also, most of the CTDs will have non-specific interstitial pneumonia, which is classically seen in almost all CTD. One exception is the rheumatoid arthritis. Rheumatoid arthritis will have usual interstitial pneumonia pattern. What is UIP and what is NSAP? You read about it and let me know. So that one or other exception, UIP is generally mostly idiopathic, but one of the main cause of the usual interstitial pneumonia is rheumatoid arthritis. All of the other CTDs cause non-specific interstitial pneumonias. So then you have pleural effusion, pulmonary nodules. In the case of the Kaplan syndrome, where the active rheumatoid arthritis is RF factor positive with associated coal miner workers, where pneumoconius is there. So the nodules can be seen, and they can have vasculitis or cryptogenic organism pneumonia. They're all ILDs. I'll discuss about ILD in the separate class. Cardiac effusion, you can have pericardial effusion with valvular lesion like MR. MR is the classically seen in almost all CTDs. Rheumatoid arthritis, SLE, everything MR is the most common, except in the case of spondyloarthritis where AR is seen. In the case of ankylosing spondyloarthritis and psoriatic, where AR is more common. Remaining most of them have mitral regurgitation is the most common thing. They have cardiomyopathy, heart failure. So all the CTDs, or any chronic disease can cause amyloidosis. All. It is inflammatory bowel disease, whether it is ankylosing spondylitis, whether it is rheumatoid arthritis, any chronic inflammatory disease can cause amyloid A deposition, serum amyloid A deposition in the kidney can cause amyloidosis in the case of any case. Serum amyloidosis in all these cases, there is a secondary amyloidosis, and it can cause membranous nephropathy also. I'll discuss about nephropathies separately. It can cause hypoandrogenism because of the chronic inflammatory stage. Rheumatoid nodules can be seen in the extensor surface, especially on the oleocrinon surface, and also ulnar aspects. You can see in the below the knee, below the patella, you can see they have osteoporosis. They can have vasculitis also. They can present with mesenteric ischemia also. One of the classical changes is cervical myelopathy. I already told you this in the case of approach to neck pain and all, where the patient will have neck pain in the case of the tingling, the tinnitus and vertigo episode, where the patient told tinnitus and vertigo because of the disturbed sensing of mechanoreceptors about the head movement in the neck. So the cervical myelopathy is also a possibility because Atlanta axial joint is also involved in the case of rheumatoid arthritis. Generally, patient will also have hematological manifestations like anemia, thrombocytopenia, that can be hemolytic anemia with immune thrombocytopenia, Felty syndrome, neutropenia, splenomegaly with rheumatoid arthritis is Felty syndrome. They can have lymphoma, that is large granulocytic lymphoma or diffuse large B-cell. DLBL is the most common lymphoma in the case of rheumatoid. These are all the manifestations you see in the case of rheumatoid arthritis. The systemic manifestation in our patient, we have shortness, or the patient might be having some pleural effusion, unilateral exudative pleural effusion, or some ILD, which is usual interstitial pneumonia, is possibility in this case. Maybe patient is complaining of SO because of the anemia also. That is also a possibility. So this is the systemic management. How do you manage this case of rheumatoid arthritis? Generally, all the cases of rheumatoid arthritis, initially, if you define the criteria, you classify it, you diagnose the criteria, There is also disease activity index. There is rheumatoid arthritis disease activity index also is there. You need to calculate the disease activity index. That is beyond our scope of discussion. When I'm discussing rheumatoid arthritis, I'll tell that. But how do you start the treatment? You generally give NSAID. Most commonly we use naproxen for the treatment. Naproxen is given around 250 mg, 550 mg BD or something for initial 5 to 7 days, along with the some dose of slow dose of steroid till we give DMARDs. So disease modifying agents like methotrexate. Generally what we use non-routinely is the methotrexate is what routinely we use around 7.5 mg to week or 15 mg peak along with folic acid. Definitely we should give folic acid and remaining other days. Like if you are giving let's say 15 mg per week of methotrexate on Sunday, you give once a week only methotrexate, 15 mg you give on Sunday. Remaining Monday to Friday you give folic acid 5 mg OD so that you don't go into the bone marrow suppression, because methotrexate poisoning, not methotrexate side effects are, one is hepatotoxicity, one is it can suppress the bone marrow like cell differentiation because it suppresses the folate pathway. So that is one of the important. You should always give folic acid along with methotrexate. How do I treat this patient? I give naproxen 500 mg BD along with Vislon 5 to 10 mg for initial 5 to 7 days till the methotrexate takes over, till the patient's joints and supplement. So along with methotrexate 15 mg once a week, along with folic acid, along with B complex and calcium supplementation to prevent the osteoporosis. That is the treatment. Naproxen 500 mg BD along with Vislon 5 to 10 mg. 10 mg you can also 10 mg based on how much significant symptoms are there. Till the methotrexate will take time to act. So till that methotrexate Vislon 10 mg, then slowly you can taper off the steroid and continue on methotrexate. Methotrexate 15 mg once a week along with folic acid 5 mg on the other days, along with B complex and calcium supplementation. Any patient that generally present with generalized body pains in this case may be having underlying vitamin D deficiency also. Most of the patient, that elderly patient that is coming into our OP will have generalized body pains also. They'll have some amount of vitamin D. So always correct the vitamin D deficiency, which is common in our setup. Case 2. A 24-year-old female known case of SLE presented to OPD with complaints of joint pains of small hands with deformities. So if you can see in this X-ray, there is significant deformity. You already know you might have this SLE related arthropathy. So this might have deformity. This is called Jacquard's arthropathy. So as you can see from the previous X-ray, there is no erosions here. There is no joint erosions here. You can see joint erosions here. Here you can see joint erosion. But here there are no joint erosion per se, but there are significant deformities are there. There is periarticular osteopenia there, but there are significant deformities here. This is a case of Jacquard's arthropathy. So generally Jacquard's arthropathy is generally seen in SLE. SLE can present as multiple manifestations. It can generally present as arthropathy per se, without any arthritis, no swelling or something. Generally present as arthropathy also, that is Jacquard arthropathy. Jacquard arthropathy is due to the laxity of joints per se, laxity of ligaments per se, rather than the joint space involvement. So you can present as a laxity. Jacquard's arthropathy is one you can present as non-erosive arthritis. Generally present as arthritis without any erosions also. If it is associated with rheumatoid arthritis, that is called lupus, where rheumatoid arthritis and SLE both are there, then it can cause erosions. So there are two different kinds of arthritis: erosive arthritis, non-erosive arthritis. Erosive arthritis where you find erosions in the bone, that is there. Erosive arthritis are generally all rheumatoid arthritis, psoriatic arthritis, juvenile idiopathic arthritis, or chronic gout arthritis, where all peripheral spas and psoriatic peripheral spas like psoriatic arthritis, rheumatoid arthritis, juvenile idiopathic arthritis, and lupus, mixed connective tissue disease. These are all erosive arthritis. Whereas non-erosive arthritis, where you don't find significant erosions in the hand, that is SLE. Almost all CTDs are non-erosive arthritis except MCTD, RA, psoriatic, where they have significant erosions in the bone. Remember, erosive rheumatoid arthritis, psoriatic arthritis, lupus and MCTD. These are the common things that we find in erosive arthritis. Generally, almost all SLE, sarcoidosis, they're all non-erosive arthritis. So this is the case 3. A 60-year-old female elderly present with history of recent loss of her husband, present with generalized body pains and cannot be localized. So when you are coming a discussion about this patient, female, she's generally most of our patients will come with generalized body pain. I am having pain in the shoulder, I am having pain in the hip, I am having pain everywhere in the body. So generally I'll give you a brief instruction before telling what is this is the case. So generally we tell tuberculosis is the greatest masquerader of many things in the world. It is the greatest mimicker of many things, because tuberculosis can present at n different number of waves. And also SLE can present in n different number of ways. Sarcoidosis can present in n different number of ways. Lymphoma can present in n different number of ways. So it is the closest mimicker of you. Whenever you see a case, the TB is always a differential. SLE is always a differential. Any fever, SLE is a differential. So it is a mimicker of many things. So they are all rare. SLE is a very rare thing, and TB is also rare in Western countries, especially. It is common in India. But one of the classical symptoms, which is, though it is the closest mimicker, it is a very common common. It is a very commonly seen in day-to-day practice, which is called fibromyalgia. Fibromyalgia is very commonly seen. It is the closest mimic of many arthritis and many arthralgias. So they are most of functional disorders. It is a problem in the central pain processing pathway. They have underlying some anxiety, some depression, some irritable bowel disease or something. Some they have some functional disorder along with it, or sometimes the patient will have diffuse joint pains. There are certain tender points where you can check. You can check for that. I'll mention what are the tender points you need to check also. So you need to check the tender point. They'll complain pain whenever you're pressing on the tender point. They'll complain of pain. They are non-localized pain. They'll complain pain everywhere. There most of them are like functional disorder associated. So it's fibromyalgia. Always think of fibromyalgia when patient is complaining of diffuse pain. You can give in them duloxetine or amitriptyline or some muscle, some tricyclic antidepressants in them. So that can be of more helpful. So always joint pains need not be some rheumatoid arthritis or some SLE or some osteoarthritis. Always need not be some inflammatory related cause. Most of them are not in the joint line. Fibromyalgia pains are not in the joint line. They're around the points of tendon insertions. Tendon insertion points are where they're not. The pain is generally not in the joint line. There is no associated swelling or nothing is there. They complain diffuse pain all over the body. At the tender points, if you check, press at the tender points with significant pressure, they'll complain of pain. So fibromyalgia, though it is the closest mimic, it is more common. It is very common in our day-to-day practice. If any patients you are not finding any cause, like the patient is not having any significant joint swellings, no inflammatory arthritis is there, the patient is still complaining of multiple joint pains here, tenderness is complaining tenderness here and there. Try a dose of duloxetine, maybe it will help them. So that might be a case of fibromyalgia. So fibromyalgia is very common in our day-to-day practice. So this, a 40-year-old male who is alcoholic present with the complaints of toe pain and ankle pain, which started overnight, increased pain over last 24 hours, history of similar episode 1 year ago. So this is a 40-year-old male, alcoholic. So he's complaining of pain in toe and ankle. So it started overnight. So this is a classical history of gout. So the gout, what will happen is the pain starts abruptly, especially when there is some trigger, when he's taking high protein diet, some alcohol is taking. So sometimes some diuretics can also cause, some antihypertensives like can also cause. So these all can cause the trigger that gout pain, especially alcoholics or high protein diet can trigger them. So in them the pain will start all once in a night. It peaks in 6 to 10, like in 6 to 24 hours it can peak. It lasts for 3 to 7 days. So this is a classical case of gout pain that triggered with alcohol or something, and generally similar etox. So patient will have some etox similarly 1 year ago or something. Intermittent patient will be absolutely normal. So what do you do in that acute episode? Generally what do you do is you try to give them a colchicine along with NSAID. The colchicine is one of the main treatment. With colchicine the pain will subside like anything. In 1 or 2 days the pain will subside. So colchicine along with NSAID. Later on, once the acute episode subside, you can put them on allopurinol or febuxostat based on the kidney. Get the kidneys. Allopurinol can't be used in the renal failure. So that's why initially you give colchicine along with NSAID. Later on, for the prevention, after the acute episodes after, you can put them on the prevention prophylaxis with some anti-hypouricemic drug like allopurinol or febuxostat. This is a classical case of gout where you can see the tophaceous gouts, this is tophi deposition. There is martel sign is there where overriding of margin is there, and also there is significant joint erosion. This is a chronic gout. That is why generally acute gout is not erosive. This is a chronic gout where the significant erosions are there. So overhanging margins are there. You can see the overhanging margins here. There is tophi deposition. There is erosions are there always. This is mostly a chronic gout. In acute gout, generally chronic gout occurs after 5 to 6 years after the initial gout episode. So gout will have a chronic course like that. So 60-year-old male, known case of diabetes, present with complaints of shoulder pain and stiffness in rotating the shoulder in both active and passive movements. So generally this is a case of 60-year-old male presented with shoulder pain or something, which is having stiffness, and he is complaining, I'm not able to completely move my arm or something, rotate my arm or external rotate. There is some, I feel pain and stiff. It is feeling stiff. So this is a case of frozen shoulder. Adhesive capsulitis. This is one of the common things that you see in the case of diabetes, long-standing diabetes, who are uncontrolled mainly. The adhesive capsulitis or the frozen shoulder is commonly seen. In them, you advise some exercise and physiotherapy and put some ice pack or something, so that a warm pack or something to relieve that frozenness. So generally they will have different phases. Initially pain and stiffness is there, later stiffness will be there, later they will recover. So there are 3 stages. So pain and stiffness is the initial stage, later the stiffness will come, later the stiffness also will resolve. So you advise some exercise and warm compress, and so that will relieve. This is the case of frozen shoulder. Always in diabetic who is present with restricted movement and pain and stiffness in the shoulder, you should always look for the frozen shoulder. A 60-year-old male, elderly female present with complaints of bilateral shoulder pain and history of restriction of movements of shoulder movements, and X-ray showed this. So if you can see in this example, this is a elderly female present with bilateral shoulder pain. Initially, though this is only present on the one side, there is history of restricted movements and shoulder movements, and X-ray showed this. You can see in the X-ray there is a calcific depositions here. So this calcific deposition are calcium phosphate deposition. So calcium uptake crystals are there. So these are calcium uptake crystals are deposited, especially in the case of elderly. That can be due to the this deposition can be seen especially in the case of there are two types of calcific deposition. There are dystrophic and metastatic. Dystrophic is due to any trauma or injury that can cause dystrophic. There is a tissue loss or any trauma or injury, that is dystrophic calcification. Metastatic is seen in the case of hypercalcemia. Some hypercalcemia can be due to hyperparathyroidism or some malignancy where the calcium goes on and deposits in random places. It can deposit in hand tissues, it can deposit in the hand joint, it can deposit in the shoulder joint, it can deposit in the muscles also. That is metastatic calcification. So this is a classical case of calcium uptake deposition, most commonly seen in elderly. Bilateral shoulder pain, this is called Milwaukee's shoulder, where you find the calcium deposition in the rotator cuff muscles. So it's called Milwaukee's shoulder. They have restriction of movement in the bilateral shoulder joints. This is the calcium uptake crystals are deposited. How do you test it? You do the synovial fluid aspirate and you check for the birefringence. They're generally negative birefringent. So this is the Milwaukee shoulder. This case of Milwaukee shoulder, you give NSAIDs. You can try if there is hypercalcemia, you can correct them also. You can try NSAIDs along with some. You can try colchicine and NSAID also, and also you can give steroids if there significant pain is there. So that is how you can address physiotherapy and all. So this is how you manage a case of this is a case of calcium uptake crystal deposition that is due to the some trauma or some injury is there. So there will have restriction of the rotator cuff muscle. Rotator cuff where the calcium deposition can occur in the other hand joints also. So this 60-year-old, most commonly seen in elderly, the negative birefringent calcium uptake crystals are seen in this case. A 65-year-old female who is obese present with the complaints of joint pains of bilateral knees with intermittent stiffness of knee joints. So what is this case? So 65-year-old female is there and present with complaints of joint pain. The knee joint pains is where they are telling with intermittent stiffness. So I already mentioned in the case of non-inflammatory joint there is intermittent stiffness that is called gel phenomenon. So the 65-year-old female, generally osteoarthritis is more commonly seen in females and elderly and who are obese. They are all the risk factors. To explain that only I mentioned this classical history. So this is common risk factors for the especially white people are also more at risk. So you will find this is a case of osteoarthritis. Like this, I also told you in the case of non-inflammatory arthritis, the joint space narrowing is not equal in the both sides. So joint space narrowing here is more on the medial side when compared to lateral side. This is the case of osteoarthritis where symmetrical joint space narrowing is there. There are some amount of osteophytes are also seen here and there. So this is the case of osteoarthritis. So here also there is small amount of osteophytes are there. So the case of where there is asymmetrical joint space narrowing is there. This is the case of osteoarthritis. Case 7. A 35-year-old female from the poor socioeconomic status present with the complaints of hip joint pain and back pain, associated with fever since last 3 months. So what is this case? It's definitely more than 3 months. It's definitely a chronic thing. So we should always think for any CTD related. But CTDs generally don't involve hip joint or any axial joints generally. It is very rare. This rheumatoid arthritis can involve cervical spinal cord, but generally CTDs are unlikely to involve. One more thing that can involve is spondyloarthritis. Generally, spondyloarthritis can involve back pain and lower back pain, but back pain and hip pain can be present in the axial spondyloarthritis, especially in the case of ankylosing spondylitis, but more commonly seen in the males. So that is a possibility. Ankylosing spondylitis is also a possibility if they are complaining significant back pain more in the night, relieved of the activity. If they are told that history, maybe this ankylosing spondylitis is also a possibility in this case. With the hip, generally in the case of ankylosing spondylitis, the hip joint and shoulder joint are that is a poor prognostic sign. Generally, only lower back pain is a good prognosis. If there is an ankylosing spondylitis in this case, then you can try naproxen is initial therapy. If it and also physiotherapy, naproxen are the first line therapies. Then you can go for TNF alpha inhibitors. So but this patient is not classically mentioning inflammatory like low back pain, more stiffness in the morning, relieved with activity. They are not telling all of those things. But poor socioeconomic status present with chronic pain and fever. So always when the hip and spine are involved, you should always look for tuberculosis, especially in our setup. So where there is where TB is very common, this might be a case of TB hip and TB spine. So generally TB generally involves spine is the most common, where the dorsal vertebra, thoracic vertebra are more commonly involved, and next is the hip joint. Hip joint is also commonly involved. Then the ankle and other joints are very rare in the case of involvement of TB, but more common involved joints are spine, hip, and knee. So always this, since a poor socio-economic history is there, chronic pain is there, fever is there, you get an X-ray done, you get a monitor done, you look for any extra pulmonary, any pulmonary manifestations of TB or any extra pulmonary manifestations of TB or any family history of TB, should always ask for all of them in such cases where the patient is having chronic history with fever, socio-economic status, where the classically patient is not present with inflammatory, there is some amount of joint destruction, there is a restriction of joint movement also is there, you should suspect TB in this case and treat accordingly. So a 35-year-old male presented with bilateral ankle joint pain associated with swelling and later on to involve the knee joints on the left side. On history taking, patient has history of loose stools 15 days ago. So this is a classical case of reactive arthritis. So you look at this case, generally what is happening is 35-year-old male present with bilateral ankle joint pains with swelling. So that is ankle. Generally ankle joint is generally not involved in many arthritis. Generally ankle joint is protected by many ligaments around it. Osteoarthritis is very rare unless you are a sports person or something. And it is also generally rheumatoid arthritis is also unlikely involved. If there is already small joint involvement, hand joint involvement, maybe in 5% of cases ankle joint can be involved. But first presentation with ankle arthritis is very rare in the case of rheumatoid arthritis. And also when you are looking at TB is also very rare in the ankle joint. And generally any gout can also be a presentation in the case of ankle joint. But generally great toe is the more common thing. But ankle joint can also be involved. But when you classically see in this case, there is history of diarrhea 15 days ago, ankle joint involved, but followed by knee joint. There is additive arthritis. Additive arthritis is more commonly seen. Additive arthritis is generally seen in reactive arthritis, that is followed by reactive arthritis is generally followed by some amount of GI symptoms or genitourinary infections. So any diarrhea, generally Neisseria and E. coli are generally not the cause of reactive arthritis. You remember that. All Salmonella, Shigella, Yersinia, they can all cause reactive arthritis. Generally E. coli and Neisseria generally doesn't cause reactive arthritis. So this might be a case of reactive arthritis followed by some GI symptoms. So secondary to GI, male to female ratio is 1:1. Males are equally affected as females in the case secondary to GI. When you come into the genitourinary, any urinary tract infection, females are more commonly affected. The ratio is 9:1 after genitourinary infection, reactive arthritis. So reactive arthritis is classically present. Reactive arthritis generally involves the lower limb joints. That is ankle, bilateral asymmetrical ankle joint involvement followed by addition of some knee joint or subtalar joints are involved. That is additive arthritis. Additive asymmetrical arthritis is a classical presentation of reactive arthritis. Generally it resolves on its own. Generally reactive arthritis generally resolves on its own. You can give NSAID therapy for the meantime. So sometimes, especially in the case of if the patient, you can test for HLA-B27 in these patients like reactive arthritis patients. In all peripheral spots, you can check for HLA-B27. If HLA-B27 is positive in this case, there is a risk of patient going to chronic reactive arthritis. In then the drug of choice is sulfasalazine. Sulfasalazine is the drug we use in the case of chronic reactive, but very rare. Very few patients go into the chronic reactive arthritis. So those at risk are mainly HLA-B27 positive. If you check for them, they'll have keratoderma belanregica. They can also be seen in the case of reactive arthritis symptoms. So you can look for the other manifestations also in the case of reactive arthritis. You can look for the eye manifestations also if they are present. Generally uveitis, anterior uveitis or something might be present in the case of reactive arthritis also. So this is the case of reactive arthritis. Initially you manage with mostly secondary to some GE in the case of males. In females most commonly seen due to genitourinary infection, you manage with naproxen. If HLA-B27 is present, maybe they can go into chronic where they manage with sulfasalazine. This is the case of reactive arthritis. A 35-year-old female has presented with complaints of bilateral small joint pains on both hands and asymmetrical, and has history of scaling on elbows and scalp and nail changes are seen. So this is a case of, you can see there is asymmetrical involvement. So the asymmetrical hand joint, this might not be. Generally asymmetrical joint involvement is rare in the case of rheumatoid arthritis. Rheumatoid generally involves symmetrically and classically spares DIP joints, but psoriatic arthritis also involves DIP joint. This is a classical case of psoriatic arthritis. You can see the history of scaling in the elbow and scalp, and all the skin lesions are there, nail changes are there. Is a classical case of psoriatic arthritis where asymmetrical involvement is more common. Generally rheumatoid arthritis does not involve symmetrically, and also rheumatoid arthritis spares DIPs. Psoriatic arthritis involves the DIPs. So this is a case of peripheral SPA, it's a case of psoriatic arthritis. Psoriatic arthritis is classified based on Casper's criteria. Evidence of current psoriasis or personal history, any family history or previous history of psoriasis is taken into consideration. Typical psoriasis nail dystrophies. There is onycholitis, yellowish color discoloration of ridging. There are classical nail dystrophic changes. You can read about them. A negative result of rheumatoid factor should be negative. Either current dactylitis or history of dactylitis. Any finger changes, inflammation, dactylitis, swelling of the dactylitis can be seen. That is and radiographic evidence of just articular new bone formation. So psoriatic arthritis is one of the aggressive arthritis where new bone formation is seen in the case of hand. This is the Casper criteria. Anything more than or equal to 3 points is considered as a Casper criteria is used for psoriatic arthritis. Negative RF factor, any history of psoriasis in the history, any nail changes of psoria, any current dactylitis or dactylitis is like swelling of the finger or swelling of finger, and radiographic evidence of gestacular new bone formation. This is the Casper criteria. And also there is one more classification for psoriasis, right and mole classification, where symmetrical, oligoarticular. The classification is called right and mole classification, where the 5 different classifications are there in the case of psoriatic. Read about right and mole classification of psoriatic. It is present and is there in the Harrison. Read about it and let me know. So case 9. A 20-year-old male presented to OPD with complaints of acute onset chest pain and shortness of breath. And history taking, he's having history of eye problem and also history of chronic back pain. So a 20-year-old male presented with the complaints of acute onset chest pain, so and shortness of breath. So you might be thinking why there is a history of chest pain and shortness of breath, and why there is an eye problem. Generally, all the cases of spondyloarthritis, like that is ankylosing spondylitis, which is a axial arthropathy, and the peripheral spondyloarthritis like reactive arthritis, enteropathic arthritis, and psoriatic arthritis, which are peripheral spasms. Generally, they have some eye manifestations. Generally, that is called alternating acute anterior uveitis. That is seen in the case of ankylosing spondylitis mainly, which is acute alternating anterior uveitis. Generally, if this time this eye is involved, next time then the other eye is involved. That is alternating anterior uveitis. So that might be a cause of eye problem is there. And acute onset chest pain and shortness of breath. Generally, what happens in the case of axial spondyloarthritis is it involves it is at risk of aortic regurgitation. So that might be a cause of acute chest pain and shortness of breath in the case. The other cause of shortness of breath that can be explained with in the case of ankylosing spondylitis is ILD. That is upper lobe predominant ILD. That is upper lobe predominant ILD is most commonly seen in the case of ankylosing spondylitis. So that might be present. That is might be a case of AR with upper lobe predominant NSIP is seen. And eye problem that may be acute at alternating anterior uveitis. One exception of anterior uveitis, posterior uveitis is seen in psoriatic arthritis. All other spondyloarthritis generally anterior uveitis is psoriatic arthritis is one thing where posterior uveitis is seen. So, and also on history taking chronic back pain is there. So this chronic back pain might be inflammatory. If you ask them deeply, maybe he will tell there is stiffness in the morning, more in the night, and relieved with activity. That is inflammatory. There is a case of classically seen in the case of there is a case of ankylosing spondylitis. You can do Schauber's test where the on bending the difference should be more than 15 centimeters. You read about Schauber test, how to do it. Generally you mark 5 centimeters and 10 centimeters. You ask them to bend down. The difference in the distance the distance between the should be increased more than 15 centimeters. If it is less than 5 centimeters, that means a restriction movement is there. That is suggestive of ankylosing spondylitis. So this is the case of ankylosing spondylitis where you give NSAIDs as initial therapy, and then you can go and give physiotherapy also is advised, and AR and other manifestation should be managed accordingly. And if still the activity is still persistent, then you can go for TNF alpha inhibitors. But most of the methotrexate and sulfasalazine has no effect in the axial arthropathy. So that is one more important thing I am going to explain you here. So this is one more thing. So you can see this is called shiny corner sign or Romanas sign, which is seen in the case of ankylosing spondylitis. So this is also, you can see the bamboo spine picture and dragger spine. And generally on ankylosing spondylitis can also involve C5, C6, which is the most common site of bone fracture or something. That is the C5, C6 can also be involved in the case of ankylosing spondylitis. This is the case of bamboo spine or railroad spine. Can be seen this Romanas and various shy corners, calcifications are seen in the end. So here you can see sacroiliac inflammation is seen in the case of them. So generally in the case of ankylosing spondylitis, there are two different things: radiological spondyloarthritis and non-radiological spondyloarthritis. What is radiological and non-radiological spondyloarthritis? If you see it on X-ray, it is radiological spondyloarthritis. If you see the changes on X-ray, that is radiological spondyloarthritis. If you have to take an MRI, that is non-radiological spondyloarthritis. Generally, only 5% of cases of spondyloarthritis are radiological spondyloarthritis. Most of them are non-radiological spondyloarthritis. Only 5 to 10% of the non-radiological SPA will progress to radiological SPA over 5 to 10 years. So, if you see it on X-ray, it is called radiological SPA. If it is not there, it's non-radiological SPA. Maybe they have 5% to 10% risk of patient going into the spondyloarthritis radiological SPA in the future. So they should be kept on follow-up. If they have pain, they should be put on NSAIDs and physiotherapy. So this is the case of ankylosing spondylitis. So this is the defining criteria. If there is sacroiliitis and in imaging, the classical SPA features are there. These are all the SPA features: inflammatory back pain, arthritis, enthesitis where tendons insert on the bone, anterior uveitis, dactylitis, psoriasis, Crohn's disease, colitis, the good response after NSAIDs after 3 to 4 days. If you they want, if you the joint pains are resolved, family history of SPA is present, HLA-B27 is there, elevated CRP. These are all the SPA features. If the patient has sacroiliitis and imaging, that is sacroiliitis and imaging, any active inflammation and MRI highly suggestive of SPA, or definitive like any X-ray imaging that is suggestive of SPA also. Along with that, one feature is present. If there is an inflammatory back pain, arthritis or enthesitis or uveitis or dactylitis or psoriasis or Crohn's disease or ulcerative colitis, any response to HLA-B27, all of these, any of them, one is present, that is called as axial spondyloarthritis. The criteria is first more than 3 months symptoms should be present. At least more than 3 times by inflammatory back pain should be present, and age should be less than 45 years. This is the criteria, first applied criteria. After that you take a test. Or HLA-B27. But HLA-B27 I doubt it, because many patients are positive HLA-B27. Only 5 to 10% patients with HLA-B27 positivity will develop SPA. But all the like 90% of patients with SPA has HLA-B27 positivity. But in normal population also many patients has HLA-B27 positivity. Only 5% will have SPA or something. So maybe, but it should always be interpreted in the case of if the patients have symptomatology or not. So that is more important in the case of this case. So this one more, substantial release of back pain after 24 to 48 hours of NSAID. This is one more thing. You can get naproxen if there is significant pain relief, that might be an inflammatory back pain. So this is a lower back pain for more than 3 months. If diaphnea to radioelevation, it's ankylosing spondylitis is present. If it is absent, you look for the other history, and HA is there. If there are more than 4 features are present, then it's SPA. Otherwise, check for HLA-B27 positivity, and if it is positive, it is axial spondyloarthritis. If 2 to 3 are present, 2 to 3 features are present, then you check for HLA-B27 positive. Compelling, it is excellent. If you are still in doubt, only 2 to 3 or 1 to 2 features are there, it is not classically presenting as axial spondyloarthritis, you can get an MRI done, and MRI will suggest you of axial spondyloarthritis. Here definitive is present means X-ray findings. So if you are in doubt, get an MRI done. If it is suggestive, then the axial spondyloarthritis is possibility. Case 10. A 90-year-old girl presented with fever, rash and joint pains of knees, hands and elbows, more in the morning, relieved with activity since last 10 days. So what is this case? So this is a 19-year-old female. So this is a case of presenting as having fever, rash, joint pain since last 10 days. It's inflammatory joint arthritis. What do you label it? So this is acute history. So maybe patient might be having first presentation of rheumatoid arthritis also, or some first presentation of some SL is also a positivity. You can get ANA and RF and CRP and ESR done. But first always look for a viral infection. Patient is having fever and rash also. So parvovirus B19, measles, chickenpox, mumps, many can cause all viral arthritis. Viral fevers can cause migratory arthritis, and even acute rheumatic fever also can be a possibility in this case, where patient can have fever, rash, and joint pains. Carditis can be manifested. Acute rheumatic fever is also a possibility, but acute rheumatic fever generally seen in the case of children less than 15 years is more common presentation of acute rheumatic fever, but that is also a possibility. You need to rule out all of them before labeling a case of chronic condition like rheumatoid arthritis. But for me, this is mostly a case of viral arthritis or something where patient will resolve on its own. So might be a parvovirus B19 or some other infection where there are common causes of viral related polyarthritis. Case 11. A 24-year-old man presented with complaints of shortness of breath and bilateral ankle joint pain and swelling. So generally very few conditions involve the ankle joint. One I told you, one is gout. Next is reactive arthritis, I told you. The next thing, a 24-year-old man presenting with shortness of breath and ankle swelling ankle joint. This is classically a case of sarcoidosis, where Lofgren syndrome is seen. You can find erythema nodosum as seen, and also you can find bilateral ankle joint arthritis, which is classically a Lofgren syndrome. So sarcoidosis is one condition that can present as ankle joint arthritis. You will have X-ray, bilateral hilar lymphadenopathy might be there. Might be the scalding classification of sarcoidosis. If you want, you can read about it. So, but to this case, when I'm discussing about sarcoidosis, I'll tell you about what are the clinical manifestations of sarcoidosis. But sarcoidosis is one condition where can present with ankle joint arthritis along with erythema nodosum. So ankle arthritis is one of the common things that is seen with Lofgren syndrome as a part of sarcoidosis. This might be a case of sarcoidosis where you give trial of steroids, 40 initially 1 mg per kg or 0.5 mg per kg, steroid and slowly taper it off. So that patient might improve in this case. Or sometimes if it is asymptomatic, it's mildly symptomatic, you can give NSAIDs and just wait and watch approach. So there is one more case I have seen. So this is a case came in our CPC discussion. A 35-year-old female diagnosed with tuberculosis. So she is having pulmonary with pleural effusions and all, but she should also develop the bilateral knee joint pains. So So she developed a bilateral knee joint pain. They aspirated the fluid. They checked for the synovial fluid. Generally, in synovial fluid, how do they differentiate between the inflammatory and non-inflammatory is based on the cell count. If the cell count is less than 2000, it is non-inflammatory. More than 2000 is inflammatory, and generally in bacteria, more than 50,000 to 1 lakh will be there. So the cell count is generally inflammatory more than 2000, but the no bacteria or PB can be isolated from the any synovial fluid. So they thought, what is the cause for that? And also there are skin manifestations also present. So there is a cause that case was finally diagnosed to be a case of Ponson's disease. That is due to the reactive effusions present because of the secondary to TB. So that is more of, but say joint is not affected with TB, but due to the reactive effusions secondary to TB. So it is a case of Ponson's disease. Generally they resolve with the ATT treatment. So there is a case of Ponson's disease. You read about Ponson's, that is a very interesting case. I'll tell you the case report. I'll send you the case report also in the group. But that is a very interesting case where there is no active TB in the joints per se, but there is active TB somewhere in the pulmonary where we are giving ATT. But here there are some skin manifestations and some joint effusions which are inflammatory, but it's not showing in MTB cultures and all. So that is a case of Ponson's disease. An 18-year-old boy presented with complaints of fever which is daily occurring with a rash. So on joint pains and on examination, patient has lymphadenopathy. So any 18-year-old boy, he is an adolescent, so there is fever occurring with rash, joint pains are there, lymphadenopathy is there. So first thing, I always told you, any acute infection, you should always look for any any viral infection is there. Viral infection is always a possibility in this case. You need to look for the EBV, CMV and all. You should need to look for any infectious mononucleosis also is there. You can check for the EBV antibody and CMV antibody, and a monospot test can be done. Any atypical lymphocytes can be checked. That is one possibility. But you can also check for the acute rheumatic fever also. That can also be positive. If the patient is having sore throat history or something, fever is there, and rash is there, joint pains is there, acute rheumatic fever, some secondary to some strep infection is a possibility. Next, patient is having fever, joint pains and rash and has lymph node. Maybe Kawasaki. Generally Kawasaki present at less than 5 years, but conjunctivitis and rash and all, maybe Kawasaki is a possibility, but rare. At this age it is very rare. Kawasaki vasculitis can also present this way. That is very rare. But one more thing, fever occurring with rash, joint pains. So one more thing, after excluding all the causes like any infectious causes, all secondary causes, you can check for rheumatoid. This can be a first presentation of rheumatoid arthritis also. So that can also be present. HIV can also present. HIV sometimes initially acute stage HIV can also present with fever, rash and lymphadenopathy. In initial stages, in the first 1 month, 2 months after you are infected with HIV, generally you will have the fever, rash and lymphadenopathy is the only presentation. So that is called HIV, acute HIV syndrome, where the fever, rash and lymph nodes are the presentation. After 3 months, if they are persistent after 3 months, it's called persistent lymphadenopathy of HIV. But that HIV can also present this way. So after urine all infectious causes and CTD causes, there is one possibility that is called adult onset Still's disease. So that is very common. After urinating out all the causes, that is one of the common presentation in the case of adults and people, or at least 18 to 25-year-old people, where the patient will have fever, joint pain, some splenomegaly, some lymph nodes, some cytopenias will be there. So eversent rash, classically they will present with rash. At the height of fever, rash will be there, then it will subside. Only every day fever will come, at the height of fever, rash will be there, it will subside once the fever is subsided. That is called eversent rash. That is classical terminology that is used in the case of adult onset Still's disease. At the height of fever, rash will be there, after that it will subside. So that is a classical eversent quotidian fever rash that is classically seen in the case of adult onset Still's disease. That fever is there occurring daily with rash. That is a classical kind of Still's disease. The criteria used to diagnose adult onset Still's disease is Yamaguchi criteria, where fever should be more than or equal to 2 weeks. Here they mention 1 week. Generally more than or equal to 2 weeks is there. Arthritis and arthralgia should be more than or equal to 2 weeks. Typical rash, eversent rash that is present at the height of fever, and WBC more than or equal to 10,000 with 80% pollination. Any minor criteria, sore throat or lymphadenopathy or splenomegaly should be present. Abnormal alpha LFT and negative ANA and RF. So ANA and RF should be negative, and exclusion of all infections, malignancy, rheumatological disease should be excluded before labeling it as adult onset Still's disease. So RF and ANA should be negative. All infections and viral infections all should be ruled out before labeling it adult onset Still's disease. So the case of adult onset Still's disease is where you give steroids for the treatment. So this is also a possibility. We have seen many cases in the NIMS where we labeled it as an adult onset Still's disease. They can also go into HLH. What is HLH? I'll tell you later. So this is a case of adult onset Still's disease. Very interesting case where 18-year-old you don't not finding any cause, where they have fever with eversent rash. This you might have seen them in the ward, but you might not have known what is the AOSD presents as. You can use this criteria to diagnose it. After ruling out ANA and RF, all infections and malignancy, viral infections you rule out. If it is persistent more than or equal to 2 weeks, you can label it as adult onset Still's and can try a dose of steroid. Maybe the patient's symptoms will come down. A 50-year-old male known case of hemochromatosis developed with fist pain and pain in the metacarpals. So you can see in this case hemochromatosis classically causes CPPD, calcium pyrophosphate disease mutation. So calcium pyrophosphate disease generally is a mimicker of many things. It can deposit in hand, it can present deposit in knee, it can deposit in ankle, it can deposit anywhere. It can present as osteoarthritis, it can present as rheumatoid arthritis, it can present as gout anywhere. Any disease it can present. So CPPD deposition is classically seen in case of hemochromatosis. It also associated with other conditions like hypomagnesemia, Gittelman syndrome, hypophosphatemia. There are many conditions that are associated with the CPPD. One of the classical thing is hemochromatosis. And CPPD can also be congenitally present with ANKH mutation. ANKH mutation is one mutation that can cause CPPD deposition, calcium pyrophosphate disease deposition. So that can also this is there where the classically you see hook osteophytes. These hook-like thing they are called hook osteophytes. These are seen in the case of CPPD deposition in the case of hemochromatosis. These are hook osteophytes are classically seen in the case of CPPD related hemochromatosis. These are all the causes of calcium pyrophosphate. One is aging, osteoarthritis itself is a risk factor for CPPD. One is post meniscectomy or any joint trauma or familial genetic ANKH mutation. And primary hyperparathyroidism, hemochromatosis, hypophosphatemia, hypomagnesemia that can be due to diuretics or proton pump inhibitors or Gittelman syndrome. One patient we have seen 60-year-old female who is on chronic proton pump inhibitor that is having hypomagnesemia present with this joint pains where we found to have CPPD crystal deposition. So that can be Gittelman syndrome, can also hypomagnesemia, gout. So hypercalcemia, where hypomagnesemia is a cause. These are all risk factors, especially hemochromatosis, hypomagnesemia, hypophosphatasia, and primary hyperparathyroidism, aging, and osteoarthritis. These are all risk factors for CPPD crystal deposition, where the hemochromatosis is classically the osteophytes. So in this crystal also one more thing called crown dense appearance. What is crown dense appearance? You read about it and let me know. Crown dense, that is seen in the case of spine. What is crown dense? You read about it and let me know. So this is the crystals. So in the case of gout we have seen previously gout where negative yellow color crystals are seen. These are rod shaped crystals, needle shaped crystals. This is the crystals of gout. Where the rhomboid crystal, you can see a rhomboid crystal which are positive, blue color is positive birefringence, yellow color is negative birefringence. This positive color birefringence is in the case of CPPD. This is a calcium pyrophosphate disease deposition. This can be on as joint aspect, you can see calcium pyrophosphate disease deposition, which is called CPPD. CPPD is positively birefringent, whereas gout is negatively birefringent. And one more thing, Milwaukee shoulder, where we discussed calcium peptide crystal deposit, that is also positively birefringent, whereas stacking coin appearance is seen. A 60-year-old man complaining of headache, pelvic and shoulder pain and has difficulty in chewing food and ESR is 100 millimeters per hour. So 60-year-old male present with headache and pelvic and shoulder pain and has difficulty in chewing of food and ESR is 100 millimeters per hour. So there is definitely inflammation is there, ESR is more, and has difficulty in pelvic and shoulder girdle pain is complaining, which is not per se localized to anyone, headache is there. This is a case of giant cell, that is called, this is a case of polymyalgia rheumatica. So associated with giant cell arthritis. So polymyalgia rheumatica should always be suspect in the case of elderly, especially more than 60 or 65 years, patient present with headache and pelvic and shoulder pain, and especially. So how do you differentiate fibromyalgia? Fibromyalgia ESR won't be elevated, and so they will have tender points also. That is how you differentiate. This is inflammatory joint pain, whereas fibromyalgia is more of functional pain. ESR won't be elevated in the case of fibromyalgia. So 60-year-old male elderly present with joint pains, you check for ESR. ESR is normal, it is a fibromyalgia. So ESR, you give steroid trial in this them. So to treat the polymyalgia rheumatica, this is a case of polymyalgia rheumatica where the ESR elevation will be there, more of joint, pelvic and shoulder points will be there, headache will be there. So associated giant cell arthritis. This is steroid is a treatment for this polymyalgia rheumatica. A 30-year-old male complaining of knee pain and climbing stairs. This is commonly seen in many people. So many people complaining of knee pain only on climbing stairs are coming down, like where they're coming down the stairs. So this is due to the chondromalacia patellae. So where the patella is not, there is chondromalacia in patella that is causing knee pain on climbing stairs. There is patellar instability or trauma to the patella that can cause as chondromalacia patellae. On climbing stairs they'll have that knee pain or any, even some patients who have hypermobility in joints. Some patients can hyperextend joint, hyperflex the joints. So they also have knee pains because of the hypermobility of the joints. So they are also due to the whatever joint pain is occurring, that is due to the hypermobility of the joint. So that can also be a cause, because of hypermobility there is increased movement of the joint. That can cause the joint problems. So hypermobility itself can cause joint pains like genu recurvatum. There can also have hypermobility in joints, that can also cause joint pains. Here the chondromalacia patellae is the cause. One of my friend has chondromalacia patellae, that is why I mentioned this case. So this chondromalacia patellae is also a cause where the knee on climbing stairs they classically have knee pain. So that is also a possibility. A 24-year-old male complaining of rash, fever, and migratory joint pains. So this is the female complaining of fever, rash, and migratory joint pains. So we also discussed there is always possibility in acute joint pains. You always look for the infectious cause. So generally septic arthritis involves a single joint. Where the fever, tenderness, swollen joint, they will be very toxic at that joint. But this is a migratory fever and rash joints. This can be case of viral arthritis. I am not denying there is viral arthritis, always a possibility. Since it's a female, always rule out Neisseria also. Neisseria infection, gonococcal arthritis is also classically presents as fever, rash, and migratory joint pains. So Neisseria gonorrhea infection is one more thing where the patient will have migratory joint pains in the case of them. That is one of the viral Neisseria and this rheumatic fever where they have migratory joint pains. So in this the possibility either viral arthritis or gonorrhea or acute rheumatic fever also. Acute rheumatic fever generally present less than 15, that is unlikely. But generally these are the viral or Neisseria gonorrhea infection is a possibility. So that it might be a case of gonococcal arthritis also, where you give ceftriaxone or something. So always history, young onset, engage, reactive arthritis is positive, 20 to 40s, infections should be ruled out. All CTDs like rheumatoid arthritis, SLE, scleroderma, Sjogren's should be ruled out. Old age, always look at OA. Gout can also present an NGA, but it takes time to have a chronic gout. Like it takes 5 to 10 years. Gout can pseudo-gout. Pseudo-gout is CPPD crystal deposition. We discuss condition aging, osteoarthritis, hypomagnesemia, hyperphosphatasia. They can cause CPPD deposition that can occur in knee or ankle, anywhere CPPD deposition. But they can only be diagnosed by synovial fluid aspirate and crystal. So all crystal diseases like gout, all this CPPD, calcium oxalate or calcium. Calcium oxalate disease deposition is generally seen in CKD patients. So all CKD, if any CKD patient that is coming to you with joint pains, always look for the calcium oxalate deposition, do a synovial fluid aspirate and look for the calcium oxalate crystals in them. Mostly management is NSAIDs and colchicine or some steroid treatment can be given for the inflammatory joint pains. But CKD, calcium oxalate, CPPD, you look for any trauma or hypomagnesemia or hyperphosphatasia or hyperparathyroidism. In the case of gout, alcohol or protein, high protein diet, and some congenital conditions of gout are also there like glucose-6-phosphate dehydrogenase deficiency or fructose 1-phosphate or Leishman syndrome. They can also cause gout, but they are very rare. But their pseudo-gout is one. In old age, always look for polymyalgia rheumatica, as we discussed in one case. So osteoarthritis, gout and pseudo-gout and polymyalgia, all crystal diseases generally occur in the elder age. So all crystal arthropathies, mostly. But young reactive arthritis infection, CTD should be ruled out. In male, gender any male difference, male gout is common. Axial spondyloarthritis is also more common in male. Generally, reactive arthritis is more common in females, especially in genital infection. Inflammatory. Enteropathic arthritis is one more thing, where Crohn's and ulcerative colitis. Like I'll give an example in our G when I'm doing my MG posting. A 40-year-old male presented with large knee joint arthritis, who is a known case of Crohn's disease. So that is enteropathic arthritis. So enteropathic arthritis are equally affected in male and female, where enteropathy associated with the joint pains. That is enteropathic arthritis. Enteropathic arthritis is also a possibility where you give TNF alpha inhibitors and NSAIDs. So in the treatment is NSAIDs and so when there is a background ulcerative colitis or Crohn's disease, you should always also suspect the enteropathic arthritis also. So male generally ankylosing spondylitis and gout are common things. In females, SLE and rheumatoid arthritis is one more thing. And gout is extremely rare in premenopausal. You should not label a premenopausal, especially in a 40 or 50-year-old female coming into you with a toe pain or something. Don't label them. Gout is extremely rare. So because uric acid levels increase in puberty in males and increase in females after postmenopausal age. So that is important thing. Gout should not be labeled in the case of premenopausal females. So any patient any female menstruating, they won't have gout. It is very rare. So drugs, always look for any drugs and diuretics or steroid usage, diabetes, hypertension, as in the case of frozen hypertension, antihypertensive can cause hyperuricemia, any TB history, and food habits in the case of alcohol, in the case of gout, obesity can cause osteoarthritis, endocrine, even this growth hormone excess, acromegaly can also have joint space problems where there is excessive joint. Generally, joint space narrowing is seen in many cases, whereas widening of joint space is in the case of growth hormone excess. Any viral illness, chronic viral illness can also cause hematological disorders can also be looked for in the case of them. So localization, axial, I already mentioned all these joints in the case of axial, and examples of axial non-inflammatory osteoarthritis can have, and dish, already about dish is a close mimicker of ankylosing spondylitis. What is dish? You read about it, and they have flowing wax appearance. What is dish? Read about it and let me know. Ocran is also axial joint involvement, and these are spondylopreparation. Dish, read about dish mainly. So dish, what is dish? You let me know. Inflammatory spondyloarthropathy, polyarticular JA, Systemic onset juvenile idiopathic arthritis, this is also a possibility. These are inflammatory arthritis. I'll tell about JA. JA juvenile idiopathy. Why didn't mention JA is we don't see generally JA in our setup. JAs are mostly pediatric case. When I'm discussing about rheumatology, when I'm mentioning about every system possible, then I'll explain about JA and all. Right now, when we're discussing adult population, JAs are not. Only JA that is in adult onset cell disease is the only thing we see in our day-to-day practice. Generally, we don't see JA in our setup generally. But read about dish is seen. Peripheral small joint or large joint. Small joints are MCPs, PIPs, DIPs, MTP. Large joints are knee, elbow, ankle. And acute is less than 6 more. Acute always look for septic, infectious causes, crystals, or any hematological. Like in the case of hemarthrosis. One more thing, hemophilia patients can have bleeds. They are called hematological conditions. And sickle cell patients can have joint pains. Beta thalassemia patients can have joint pains. They also can have joint pains. So they have more hematology. They're acute onset. After bleed or something they'll have. Or trauma, reactive arthritis is more acute. IBD related arthritis, I mentioned enteropathic and arthritis like Crohn's and ulcerative colitis related. RASL, ECTs there might be first presentation also. Chronic always look for RASL, ECTD, osteoarthritis, sarcoidosis, and enteropathic and synovial sarcoma. These are all more chronic in nature. For our thing, RASL, ECTD, osteoarthritis, sarcoidosis, enteropathic, we already discussed all these cases. I will discuss about orthopedic causes like tendon lesions, this pigmental villus nodular hypertrophy and sarcoma. Later on, when you want it, I will discuss later on a different presentation. So these are the different pattern: inflammatory or SLE, symmetrical or rheumatoid arthritis, or juvenile idiopathic can be symmetric, adult onset still disease symmetric, SLE symmetric, MCTD symmetric, polymyalgia rheumatica is symmetric, rheumatic fever is also symmetric. Especially if it is adult or Jacquard's is mostly a manifestation of SLE. Asymmetric, mainly all spondyloarthritis. You take all ankylosing spondyloarthritis, reactive spondyloarthritis, psoriatic polyarthritis, and these are all spondyloarthritis. All spondyloarthritis are generally asymmetric. Even juvenile posteoarticular also is asymmetric. Palindromic rheumatism can be palindromic, where the intermittently rheumatoid arthritis can present with joint flares. That can also be asymmetric. So all spondyloarthritis are generally asymmetric. Psoriatic, enteropathic, and ankylosing spondylitis. All these things are arthritis. If they are not fitting to anything, you differentiate undifferentiated inflammatory arthritis also. Any crystal arthritis is a CPPD, or Milwaukee we discussed, hemochromatitis we discussed about, and gout we discussed about, and viral arthritis infectious is viral arthritis is generally symmetrical. Bacterial is asymmetrical. Bacterial Lyme's disease are asymmetrical. Late phase will have arthritis. This is one of our essay question. Lyme disease late phase can have arthritis. So, and discover that hypertrophic osteoarthropathy, symmetrical amyloid can be present, sarcoid can present as cancer. Cancer can present as either ways. These are all miscellaneous causes where you can cause. Amyloid can cause, sarcoid can cause, cancer can cause. Sequence intermittently, crystals can cause intermittent, like flares will be there. Lyme's have intermittent. Palindromic rheumatitis is also intermittently present, that is rheumatoid arthritis presentation. Additive is seen in the case of reactive arthritis, psoriatic arthritis can be additive. Polyarticular OA also can. Initially, sometimes carpal joints, carpometacarpal joint can also be. First carpometacarpal joint is in the case of OA. Polyarticular, additive, osteoarthritis is one more thing. Reactive arthritis is one more thing, where additive is thing. Migratory acute rheumatic fever, gonococcal arthritis, one more, where migratory is seen. Additive, reactive arthritis we classically seen in our case. Psoriatic arthritis can also be additive. Osteoarthritis, one after the other joints, after based on the weight bearing osteoarthritis can be additive also. Extend mono to 2, anything more than or equal to 4 is equal to polyarthritis. So this is 1, 2, 3, 2, less than 4 actually. 4 is generally polyarticular. So acute monoarthritis you look for gout, especially grade 2, pseudo gout in the case of knee, calcific periarthritis we discovered Milwaukee shoulders in the case of calcium peptide crystal, septic arthritis, trauma, hemoarthritis in the case of hemobolia, any foreign body reaction. In the case of chronic you look for infectious arthritis like tuberculosis or some syphilis. Tuberculosis is the main thing. Brucellosis can present as chronic something. Any inflammatory like rheumatoid arthritis or SLE or something non-inflammatory causes like any trauma, there is any joint, any avascular necrosis can also present, and tumors can cause chronic monoarthritis or undiagnosed. Acute chronic, these are all mentioned. Acute polyarthritis is mainly this: rheumatoid arthritis, viral arthritis, psoriatic arthritis, reactive arthritis, enteropathic. These are all we discussed already. Connective tissue disorders. Behçet's will have oral and genital manifestation that can be discussed. That are when we are discussing about rheumatology, we will discuss about all what are the clinical manifestations of all of this. Chronic, already mentioned. These are all the causes of chronic polyarthritis. So always look at the hypermobility and fibromyalgia, soft tissue rheumatism. Always should be looked at. When there is no non-inflammatory, the joint is not involved. If this generalized osteoarthritis is not there, always look for this cause. This is the most important. These are all causes we can look at based on the systemic features and all. But there is no joint involvement. Then non-inflammatory you look for. Osteoarthritis you look for. If osteoarthritis is also not there, always look for fibromyalgia or any hypermobility or any soft tissue rheumatism is there, or any soft tissue other soft tissue involvement is there. Oligoarthritis, any spondyloarthritis or psoriasis, we already mentioned CPPD deposition. Relapsing polychondritis, one more thing where they have nasal deformity, tracheitis. I'll discuss about all of these things. These are very rare things. When we are discussing rheumatology, we'll discuss about all of these things. Mainly peripheral is a polyarticular gout and infective endocarditis. Examination. These are swelling, tenderness, limitation, default. These are all should be liquid. Any inflammatory arthritis should always, any joint examination, this should always be done. All joints. So you can see in this case, these are deformities of rheumatoid arthritis. Here you can use fan neck deformity is seen in this case of them. There is a zigzag deformity where the ulnar drift and radial shift is there. So this is the case of zigzag deformity. So this is the case of rheumatoid arthritis. These are deformities in the rheumatoid arthritis that are classically seen. Here again you can see swan neck deformity. This is thumb deformity in the case of rheumatoid arthritis. So these are the deformities of rheumatoid arthritis. I'll discuss about the rheumatoid arthritis deformities cleanly when I'm discussing about rheumatoid arthritis, but these are deformities you can see in the case of rheumatoid arthritis. So these are all the joints you should exercise. You should check for temporomandibular, you should check for the shoulder involvement, any acromioclavicular joint involvement, glenohumeral joint, elbow joint. You look for the wrist joint, carpometacarpal, first interphalangeal joint. All interphalangeal joints should be examined. Knee joint, ankle joint, all metatarsophalangeal joints and interphalangeal joints all should be examined. All should be examined. These are all the joints you should examine in the case of polyarthritis. Everything. So pattern recognition, based on the pattern you can tell what rheumatoid arthritis generally involves spares the distal interphalangeal joints. So these are all the joints can be involved. It spares the distal interphalangeal joints that can be against. Carpometacarpal joints are also not generally involved in the case of rheumatoid arthritis. So distal interphalangeal joints are generally not involved in the case of rheumatoid arthritis and mostly symmetrical. So these are symmetrical. You can see in the symmetry in this them symmetrical involvement is seen. Most common are metatarsophalangeal joints and metacarpophalangeal joints and wrist joint are most commonly involved in the case of rheumatoid arthritis. In the case of this is the case of psoriatic arthritis very symmetrically. Here 3 joints are involved, here 2 joints, and distal interphalangeal joint is involved in the case of psoriatic arthritis, which is not involved in this case. It is more asymmetrical. Random joints are involved. It is very destructive. New bone formation is seen. It is all asymmetrical. And Casper criteria and right and mole classification are seen inside psoriatic. Read about it. This is SPA. This is axial SPA where you can see the SPA involvement of axial joint, hip joint, and sacroiliitis is there. Some asymmetrical joint involvement is there. The axial SPA, mostly ankylosing spondylitis. So this is osteoarthritis. This is also psoriatic is also SPA, more of peripheral SPA. This is osteoarthritis where classically first carpometacarpal joint is classically involved. Knee involvement is seen. Ankle is rarely involved. Shoulder joints can be involved, and cervical osteoarthritis is also seen. And DAPs can be involved. The Bouchard's nodes, Hepatic nodes are seen in the case of osteoarthritis. So first carpometacarpal joints, knee joints, and cervical joints are classically seen, and DAPs and proximal interphalangeal joints can also be involved in the case of osteoarthritis. This is joint involvement of osteoarthritis. Subcutaneous node, you can see rheumatoid arthritis or osteoarthritis, whereas proximal is Bouchard's and distal is Hepatic nodes are seen. Gout you see tophi. And in the case of rheumatoid heart fever also you can see some nodules. Sarcoidosis you can see erythema nodosum. PAN you can see cutaneous nodules. Dyslipidem because of the lipid deposition can be nodules can be seen. So this is the difference appearance. So here where the anterior where the tendons, this is the place where enthesitis is seen. So where the tendons are involved. So here this is a true pain where the iliopsoas bursitis can also be seen. This is the pain radiation pattern of the true hip pain or iliopsoas bursitis. This is the meralgia parasitica. This is a radiating pain on the lateral side of the thigh. Meralgia parasitica is seen. So here tendons are involved. So tendon insertion pain or ligament insertion pain on the bone is enthesitis, which is seen in the case of spondyloarthritis. Enthesitis pain is classically seen here, where the true hip pain or iliobursitis pain is more radiating toward the loin. Meralgia parasitica is more toward the lateral side of the thigh. This is sacroiliac pain, which is seen in the case of spondyloarthritis, radiating to buttock pain, referred to buttock pain. So alternating buttock pain is classically seen in the case of ankylosing spondylitis. This is the case of sacroiliac pain. So here ischio-gluteal bursitis. So there are various bursts based on the sitting position. You have ischio-gluteal bursitis here seen here, trochanteric bursitis here seen. They are localized, more localized, where bursa they are not joint articular pains. They are periarticular pains where bursitis can be seen. These are the classical trochanteric bursitis seen here, whereas ischio-gluteal bursitis seen here. So this is involvement related. This is in relation to the shoulder joint pain. So shoulder joint classically involves So this is can be in the acroclavicular joint, is supraspinatus, rotator cuff injury, especially in elderly people who are exposed to some trauma where they have difficulty in abducting shoulder. So where the supraspinatus muscle is there, supraspinatus tendon is there, this can be involved. Rotator cuff injury is commonly seen, so this is the joint involved. This biceps tendinitis is also seen, where you press the muscle, the tendon pain will result. This is bicep tendinitis, tendon pain will be classically observed. Pressure, apply pressure on this in this. Subacromial bursitis is seen and localized to this location. So these are the, you can localize based on the anatomical location, where the which tendon is involved. Based on this location you can involve. So the glenohumeral joint is involved here. So subcapsular muscle. Generally, what we commonly see is the biceps tendinitis is commonly seen, where the pain on the pressure is, pain is released on the applying the pressure. And rotator cuff injury can be located on abducting the shoulder. Any on abduction, the pain is combination is complaining the pain that might be due to rotator cuff or tear or something. Subacromial bursitis just below the clavicle. Acromial clavicular joint, you find a subacromial bursitis or something is subacromial bursitis classically seen. So the knee, DIP is osteoarthritis or psoriatic or reactive. PIP, OA, SLE, reactive arthritis is seen. MCPs can be reactive arthritis and pseudogout and hemochromatosis we have seen. First carpometacca, osteoarthritis. This is dequerent tenosynovitis. This is the tenosynovitis you know of Finkelstein test and all. I will mention again the soft tissues again I will mention if you want me to in the separate class. Wrist can be seen in RA, pseudogout, gonococcal arthritis, many carpal tunnel syndrome. These are all the classical manifestation. Most commonly seen in the RA and pseudogout. That can all be seen in carpal tunnel syndrome where tunnel sign is seen. So these are all the things in the case of them. So these are the various drugs that can cause the musculoskeletal conditions like arthralgias, like especially quinidines, beta blockers, quinolones, acyclovir can cause, HIV drugs can cause, DPP4s can cause joint pain, like sitagliptin, linagliptin. There is one patient of me who complained of joint pains after arthralgias after starting sitagliptin especially. So I have seen that. I have seen with quinolin also. After malaria also I have seen one case where after joint starting these drugs the patient complained of arthralgias. Myalgias and myopathies, especially after startings they will complain. They complain of myopathy especially after starting, and some steroid associated myopathy and penicillinamine. After starting penicillin class of drugs they can start with myopathies, and any clofibrates, any fibrates can start with myopathy after starting statins or something. So these are all the common things. If you want to remember the entire list, it's up to you. And tendon ruptures, this is important for NEET assess, not for no. Tendon rupture, you can see the fluoroquinolones, ciprofloxacin, if you start certain drugs like ciprofloxacin, fluoroquinolones, or isotretinoins, or glucocorticoids, they can have tendon ruptures. So remember this. And gout can be prescribed with diuretics, aspirins, and alcohol can present, and moonshine, ethambutol can prescribe gout. They can all cause hyperuricemia. And drug-induced lupus, you know, and osteopenia, psoriasis, this can all be. If you want to remember, you can remember the entire list that is present in the Harrison's. If you want, you can remember the list. So next, so this is how you look. So any patient with trauma or fracture, you should look for orthopedic evaluation. If low back pain is there, fibromyalgia is always more common, very very common. If there is generalized body pain is not localizing somewhere, you have tender point also. If age less than 60 years, you should look for first tendinitis or bursitis is there. So if tendinitis or bursitis, you should like tennis shoulder, elbow shoulder, there are lateral epicondylis, medial epicondylis. You should look for the tendinitis and bursitis. If it is male, gout should be ruled out. Then rheumatoid arthritis. Then peripheral spas like reactive arthritis, psoriatic arthritis, IBD related. Then you look for infectious cause like viral bacteremia or any glucocorticoid use or Lyme. If the patient is more than 60 years, first thing is osteoarthritis always. Then you look for gout and Sugoda, which is due to CPPD. Polymyalgia rheumatica should be kept in mind. Any osteoporotic fracture, because of the elderly fracture risk is more, or any septic arthritis should be looked for. So this is the prevalence. Prevalence of fibromyalgia is very high, and like that, this is the order. The tendinitis, bursitis are very common in younger age. Gout is common in the males. In the case of elderly, osteoarthritis and gout and pseudogout are very common. Rheumatoid arthritis is common in females. If you are looking at females, rheumatoid arthritis is also common. Then you look for the other causes. In less than 60 years, psoriatic are very less common. So arthritis is bacterial. If it's especially polyarthritis, septic arthritis is very rare. So this all should be ruled out in the especially based on the age-based pattern. This is how you evaluate a case of musculoskeletal system. Initially, you ask for articular or not. I may already mention joint line pain is or there, any crepitus, swelling, tenderness, active and passive movements are affected or not, acute or chronic inflammation is present or not based on the symptomatology. Is it monoarticular or polyarticular? So if it is monoarticular, ask for red flag like any fever, anything else there. Gout, septic arthritis is possibility, fracture is possibility, carpal tunnel syndrome is a possibility. Any vascular come. Any monoarticular, always look for trauma, infection, septic arthritis, Last possibility is gout if it's especially grade 2 or something, or any vascular related compromise. Avascular necrosis is also a possibility in the case of monoarticular, especially in the case of patient on steroid or any patient is on steroid, especially avascular necrosis is very common. So in them you should rule out them. Then if it is no articular, if the patient is having articular or not, then if it is not articular, then look for any fibromyalgia, polymyalgia rheumatica. Differentiation is based on the ESR, any tendinitis or bursitis. You can completely localize where the pain is, that is away from the joint line. They'll campaign on the specific movement, tendinitis and bursitis. And any myositis also should be looked for in the case of any recent start, or any myositis also record. Look for any fibromyalgia and polymyalgia based on the ESR. You can look for any tender points are there. If it is articular, then if it is chronic or not, or acute, first rule out any infection related causes like any acute arthritis, some viral or septic arthritis, or initial crystal related like first presentation of gout or pseudo gout, or initial presentation of some chronic arthritis. If chronic, is it prolonged, first if the prolonged morning stiffness, like inflammatory or not. If it is inflammatory, chronic inflammatory arthritis, based on how many joints are involved. So if more than 3 joints are there, it's chronic inflammatory polyarthritis. So based on the joint involvement, or PIPs and MCPs and MTPs are involved, that is a rheumatoid arthritis. If they are not involved, that might be case of SLE, scleroderma, or polymyositis. So if involvement is chronic inflammatory and his involvement is not symmetric, then you look for all peripheral spas. So symmetrical is present or not. If asymmetrical, always look for spa. If it is symmetrical, then you look for PIP, MCP and MTP joint involved, which are commonly in rheumatoid arthritis. If unlikely to be rheumatoid arthritis, then consider. If it is not rheumatoid arthritis only, then you go for ANA and all. Otherwise, it is mostly rheumatoid arthritis only. So always in the case of inflammatory, always send ANA and RF. So mostly it is rheumatoid arthritis only. Sometimes other SLEs also can be a possibility. So if 1 to 3 joints are involved, mono or oligo, first TB or fungal infection is also a possibility. Psoriatic, reactive or polyarticular GI is a possibility. So this is regarding the inflammatory arthritis. Based on the symmetricity and how many joints are involved, they are classified. Most common is always rheumatoid arthritis. If it is chronic inflammatory, if DIP is involved or not, DIP, CMC, DIP and carpometacarpal joint, hip and knee joint, they are commonly involved in the osteoarthritis. If it is not there, then you look for osteonecrosis, that is avascular necrosis or Charcot arthrosis. Charcot, I'll mention again, hemochromatosis or something like that you should need to mention. You need to consider. So these are the causes of. So these are regarding the gout, where urate more than chronic hyperuricemia, increased urate that is due to obesity or metabolic factors or genes. I can mention genetic factors like glucose 6-phosphate or hypoxanthine guanine phosphorhypoxyl transferase like that is HBRT deficiency or fructose 1-phosphate deficiency. They are all causes of gout. So they can cause more than 6.85 milligram. They cause crystallization. After recurrent flares, it takes 5 to 10 years to develop the chronic gout. Initially, acute crossing inflammation is not erosive. After that only they got chronic gout. Initially, you manage with NSAIDs and colchicines and sometimes glucocorticoids. In between, you start with allopurinol or febuxostat. So that is how you get. Triggers are purine-rich food or alcohol or diuretics or rapid change in urate level, any trauma, any heart failure. So any chronic, any systemic infection that can also, they are all triggers for the gout. So this always trigger should be, urate level should be kept less than 5 to 6. Why we are not starting in the acute gout, febuxostat and allopurinol also? This thing, rapid change in the urate levels. So if you start urate lowering therapy rapidly in the acute phase, it flare up the gout more, because if there is a rapid shift also, there will be flare. So that's why you don't start allopurinol right away. Until the acute episode subside, you will give them only NSAIDs and colchicine. After the acute flare subsides only, you give. In between, for prevention only, you give urate lowering therapy like allopurinol or febuxostat or probenecid is given. So these are all the triggers. Purine-rich foods, alcohol, diuretics are all the triggers. So these are the appetite crystals, like this I mentioned in the case of 60-year-old female bilateral shoulder pain, where the calcium deposition is seen, that is metastatic or dystrophic calcification, that can be present as Kelswick periarthritis or bursitis, and can be involve many joints, or any joint can be involved. So this is the involving the. This is the regarding the calcium peptide crystal deposition that can be due to the trauma or hyperparathyroidism or calciphylaxis, that is renal failure, long-term dialysis, or some CTDs can cause, or some stroke. There is a heterotropic calcification after neurological catastrophe, where there is due to the increased mobility, there is decreased movement of that, there is diffuse atrophy of that joint. Because of diffuse atrophy, there is metastatic calcification, there is dystrophic calcification in that place. So these are all the causes in the case of calcium peptide crystals. Only remember Milwaukee shoulder in this case, where there is a calcium deposition especially in the elderly females. That is one important thing. So these are the tender points where you check occipital, These are, I told you on fibromyalgia, these are the tender points you check for. One is occipital, suboccipital insertion, trapezius you should check for, midpoint to the upper border you should check for, any supraspinatus also should be checked for, above the medial border of supraspinatus, gluteal should be checked for, and greater trochanter should be checked for along the posterior, in lower cervical should be checked for, second rib should be checked for, and lateral epicondyle should be checked for, and knee, medial to the fat pad. These all locations should be remembered. These are all the tender points you should check for in the case of fibromyalgia. Occipital, trapezius, supraspinatus, gluteal, greater trochanter, in the medial to the knee joint, second rib, lateral epicondyle. These are all the knee point. Around 18 joints are present. So these all should be looked for in the case of around more than 11 out of 18 is present that is diagnosed of fibromyalgia. These are 18. There are 1, 2, 3, 4, 5, 4, 9, 9 into 2, 18. So more than 11 by 18 is suggestive of fibromyalgia. So how do we treat? Muscle relaxant like cyclopentazepine, we try amitriptyline, duloxetine, and this can be tried. The antidepressants are not commonly used. You can try analgesics and pregabalins can also be used. Most commonly you give duloxetine or amitriptyline. So these are the thing. Muscle relaxant, cyclopentazepine also can be used. So what is this? So this is a Charcot's arthropathy where you can see the loss of arch on the lateral. Generally arch will be there. There will generally more concave structure will be there. This is the destructive arthropathy in the diabetes because of neuropathy that can be seen in leprosy, syphilis, diabetes. Any peripheral neuropathy can cause Charcot's joint where the tarsometatarsal joints are most commonly affected. So this is a case of Charcot's arthropathy seen in the case of diabetes where there is loss of architecture. This can due to the neuropathy related joint destruction. Because of the patient is not able to feel the sensation of joint, he is going into the recurrent joint injury. So this is called Charcot's arthropathy, where there is a complete dislocation. You can see the dislocation and fragmentation of especially tarsal and metatarsal joints. This is mostly related to diabetes. Most commonly we see in diabetes that can be seen in syphilis also. This can be seen in the case of leprosy also. Many cases of many causes of Charcot's arthropathy are seen. So this is the rheumatoid nodules. We can see this is in the oleocranial process. This can be seen in the finger joint. We can see where do we find rheumatoid nodules are a pathognomic of rheumatoid arthritis. So they are classically they are granulomatous necrotizing inflammatory states. So these are seen most commonly in the oleocranial process. They are seen in many states. Where you see rheumatoid nodules, let me know. But they are common seen in the oleocranial process and all. So where else you can see, you can check out and let me know. So these are Bouchet and Hebet and all. Bouchets are seen in the proximal joints. You can see if you examine your elderly grandmothers or something, you see the joint swellings of proximal and distal interphalangeal joint. They are Bouchets and Hebet nodules. So you can see them classically. Generally, where there are joint swellings of the proximal and distal interphalangeal joints are classically seen. They are called Bouchets and joint. There is mild swelling. Generally, more significantly they will be seen. But these swellings, proximal is Bouchet, proximal B comes first, then H comes next. So proximal is Bouchet, distal is H. So they are seen in osteoarthritis. So these are tophi. Tophi can be seen in many places. It can be seen in the grade 2, it can be seen in the distal interphalangeal joint, it can be seen in the heart also. Sometimes myocardium also can have tophi crystals. So they can be seen in myocardium also. They are tophi depositions. These are psoriatic lesions, classical. These are scaling lesions, psoriatic. These are nail dystrophy. These are seen in psoriasis. These are scaling seen in the case of psoriasis. Psoriasis is mostly seen in the extensor surface. So nail dystrophy, scaling, ridging, yellowish discoloration, pitting. Many changes of nail changes in the psoriasis is also very important. You learn about it. When I'm discussing about dermatology, I'll tell about nail changes and psoriasis. So antisynthetase. This antisynthetase syndrome is seen in the case of MCTDs and sclerodermas, where the syndrome in the case of myositis also you see. This is the mechanical hands where the lateral wall there is a dryness on the scaling is seen in the case of lateral borders of the fingers. This is called as mechanical hand. So mucocutaneous butterfly rash, oral ulcers, alopecia is seen in SLE, pyoderma gangrenosum, and rheumatoid nodules are seen in RA, oral and genital ulcers. These are the markers where you suspect something secondary to arthritis. Painful oral and genital ulcers, Behçet syndrome, heliotropic rash and dermatomyositis. I will discuss about myositis when we discuss. Raynaud's phenomenon, skin thickening, sclerodactyly is seen in the case of systemic sclerosis. Purpura, Henoch-Lehmann purpura, Sjogren's vasculitis. So these are all very rare. But all CTDs can have arthritis as a manifestation. As you can see in the history manifestation, based on the systemic manifestation, you can look for what kind of CTD it is. So this is scleritis. This is episcleritis. As I mentioned, episcleritis correlates with the rheumatoid arthritis disease activity. Scleritis does not cause. But scleritis is more dangerous because they can have scleromalacia perforans with recurrence. They can have perforation of the sclera. So this is already thinning of sclera is there. So this is scleromalacia perforation, where is darkish discoloration. This is episcleritis. So this is a GP, a granulomatous, even Wegener's granulomatous. GPA, granulomatous with polyangiitis, can also have arthritis. They can have upper respiratory tract infection and recurrent URTIs and LRTIs. They have retrobulbar also. IgG4 also can have retrobulbar. Saddle nose in granulomatous polyangiitis and recurrent polychondritis also. Relapsing polychondritis also one more cause where saddle nose is seen. GPA, granulomatous polyangiitis, where you have URTIs and eye manifestation, sinusitis manifestation, and recurrent otitis media is a manifestation of. These are all systemic signs where you have, if there is arthritis, if these systemic signs are there, so that you can work up for them. So there are markers that can tell. If the patient is having recurrent URTIs and recurrent otitis media and recurrent sinusitis and some retrobulbar is there, you can look for granulomatous polyangiitis. If the patient has sclerosing cholangitis and retroperitoneal fibrosis and some recurrent pancreatitis or recurrent salivary gland inflammation, you look for IgG4 related disease. If the patient has saddle nose deformity, one more thing is relapsing polychondritis and GPA. We'll discuss about detailedly about separately, but these are just clinical markers. So pulmonary ILD, pleural effusion. ILD is seen in the case of rheumatoid arthritis. Some CTDs like systemic sclerosis can cause ILD. Pleural effusions are seen in SLE and rheumatoid arthritis. Especially unilateral effusion is seen in the case of rheumatoid arthritis. Bilateral is seen in the case of SLE. Nodules, lung nodules are seen in the case of rheumatoid arthritis. Especially Kaplan syndrome is seen. That is one more thing. Genitourinary reactive arthritis, like I mentioned, gonococcal infection can have gonococcal arthritis, IBD related arthritis, enteropathic arthritis, Behçet's disease we already discussed, SLE, these are all annulus purpura, where GI bleed is very typical. Renal, SLE, vasculitis can be seen. Specific joint, temporomandibular joint. Broader specific joint, temporomandibular joint is commonly seen in the case of rheumatoid arthritis. GI we don't see commonly. Sternoclavicular, spondyloarthritis is one common thing. Rheumatoid arthritis, OA. Yes, these are axial joints. They can involve SPA. These are not basement. First carpal metacarpal joint, OA is more common. Midfoot joint, spondyloarthritis joints, juvenile idiopathic, these are very rare. We don't see them. Knee and ankle. This one more thing. Sarcoidosis, sponsets I mentioned in the case of our history where the patient is having pulmonary TB but reactive effusions are seen in the case of knee. So knee and ankle, sarcoid and sponsets we should suspect. So this is GIA. I'll mention again about GIA in the later when I'm discussing detailedly about juvenile arthritis and the rheumatology topic. So these are the common tests we use. CBP we should for like any inflammation is there, any septic arthritis, any neutrophil elevation is there. In crustal arthritis you look for any elevated ASR, CRP, leukocytes and anemia is there. So any chronic inflammatory they have AOCDs and leukocytes is commonly seen in inflammation and infection can also cause. ESR and CRP are related in the case of inflammatory arthritis. Any raised uric culture, blood culture should be sent. So serology we send for RF factor, anti-CCP, AN and HLA-B20, and especially in the case of spondyloarthritis. These are the tests we do in the case of inflammatory arthritis. And also always do for synovial fluid aspirate. Synovial fluid aspirate should always be done to look for any crystals. What is the leukocyte count? What is the viscosity? Generally viscosity is decreased in the case of inflammatory arthritis. So inflammatory, any cell count more than 2000 is inflammatory, less than 2000 is non-inflammatory. In the case of bacterial, more than 50,000 will be there. So that is how you work up for the case of inflammation. Always synovial fluid aspirate should be done in the case whenever in doubt. These are needle-shaped crystal in the case of them. As I mentioned, cells will be more than 50,000, 10,000 to 20,000 in the case of inflammatory arthritis. So these are all important in the case of inflammatory arthritis. Synovial biopsy, especially in the case of tuberculosis, sarcoidosis, ML, pigmented villonodular hypertrophy, where there is a recurrent hemorrhagic effusion of joints. So these all require synovial biopsy. TB for diagnosis, sarcoidosis for diagnosis, amyloidosis for diagnosis, PV, pigmented villus nodular synovitis, PVNS. These are all require synovial biopsy for diagnosis. Imaging, X-ray, ultrasound can be done, especially in the case of gout and rheumatoid arthritis. We use musculoskeletal ultrasound a lot. MRI also can be done when in doubt. So these are the various. This is the rheumatoid arthritis, which is classically presenting. This is a classical presentation. You can see periarticular osteopenia, joint space narrowing, and joint erosions are seen. This is a case of rheumatoid arthritis. The joint involvement, sparing of DIP can also be seen. So this is a case of there is no much of periarticular. There is no joint erosions per se. There is some amount of joint space narrowing, not significant, but you can see joint space narrowing and distally more. So this is a case of osteoarthritis where distal joints are involved, joint spaces are involved, narrowing is there, but there is no much of periarticular erosion. There is, but they are as significant as previously, but there are no joint erosions per se. But in between you can see osteophytes also. Here you can see osteophytes, here you can see osteophytes. So this is mostly a case of osteoarthritis. So DIPs are involved, mostly joint space narrowing is seen in the case of more distal joints. So the case of, and also one more thing, symmetrical joint space narrowing is in the case of inflammatory, asymmetrical is in the case of non-inflammatory joints. So what is this? So here there is the lytic lesions are there, overhanging margins are there, so erosion is there. So this might be a case of erosive hand osteoarthritis. So this is a case of erosive hand osteoarthritis where erosions are there, joint space narrowing is there. Erotic margins are this erosive hand osteoarthritis. Previous one is non-erosive. This is the case of erosive hand osteoarthritis. So here you can see joint space narrowing. Here not much of a joint space narrowing. Here you can see classically see joint space narrowing. Erosions are there. So what is this? This is the case of, here clearly there is overhanging margins. So this is a case of gout. So here clearly you can see asymmetrical, few joints are involved where there is a overhanging margins are there, joint erosions are there, there is some soft tissue which is a soft tissue density is there. This might be a ectophaseous crystal also. So this might be a case of gout. This is a case of gout. These overhanging margins are classically seen in gout. These overhanging margins and all generally seen in the case of toe, where the Martel sign, it is called Martel sign. This gout, there is called double contour sign also in X-ray. In gout you see double contour sign also in X-ray, not X-ray, ultrasound. So what is this? There is acral osteolysis and thinning. There is acral osteolysis in this case of scleroderma. There is acral osteolysis in the case of scleroderma, where this is classically there is tapering of digits. This is scleroderma case. What is this case? There is no per se joint erosions. There is some joint space narrowing is there is a deformities are present significantly when compared to the joint space narrowing. This is a case of deforming arthropathy, non-erosive arthropathy. This is a case of arthropathy, not because of the laxity of joints rather than the joint itself involved. This is a case of Jacquard's arthropathy, most commonly seen in SLE. These are the osteoarthritis. So this we can see in this case there is joint erosions are seen in the case, there is effusion and joint erosions. So classically you do it in the case of wrist. We can see periarticular osteopenia and erosions are seen in the wrist first. So in the case of radiocarpal joint, where you see in the case of rheumatoid arthritis, where you do. So that is helpful. In the case of gout you see double contour sign. So this is bone erosions and metacarpal head. So these are important. This is how we again articular and articular. Is it articular? No. Then you check for trauma, fibromyalgia, polymyalgia, tendinitis or budget. If it is articular, then you check for acute or chronic. Acute, always rule out the infectious causes and crystal arthropathies first or initial presentation. Chronic, inflammatory or non-inflammatory. Inflammatory, polyarticular or monoarticular. Polyarticular, you should look for joint involved. If it is metacarpophalangeal, PIP and DAP are spread rheumatoid arthritis, otherwise it is a SLE. If it is no symmetrically involved, then psoriatic or reactive arthritis. Few joints are involved, then you can look for any infectious causes and reactive and psoriatic arthritis. If it is chronic, non-inflammatory, if DIP and carpometacarpal first joint is an osteoarthritis, otherwise osteonecrosis. This is the regarding the arthritis manifestation.